Hello, myself Dr. Bazulika Sharma. I am a gynecologist by profession. Today we are going to discuss the female infertility. What is female infertility? By definition, it is defined as the inability to conceive after 12 months of regular, unprotected sexual intercourse for women under 35 years of age, and after 6 months for women over 35 years of age. It is said to be primary infertility when a woman has never been able to conceive, and it is called secondary infertility when a woman has difficulty in conceiving after previously having a successful pregnancy. There are multiple causes of female infertility, as under ovulatory disorder, it affects 25 to 30%, tubal and pelvic pathology 25 to 35%, unexplained infertility, it contributes to around 10 to 20%, and uterine and cervical factor, which contributes to 5 to 10%. Other contributing factors are lifestyle choices, environmental exposures, genetic predispositions, and medical history. All they play a role. Now, let's learn a bit about female reproductive anatomy and physiology. It consists of external genitalia and internal organs. External genitalia includes vulva, which includes the labia majora, labia minora, and clitoris, and vaginal opening. Internal organs consist of ovaries, which are almond-shaped glands located on either side of the uterus, and they produce eggs and secrete hormones like estrogen and progesterone. Then there are fallopian tubes, which are muscular tubes connecting ovaries to the uterus, having three sections: fimbriae, ampulla, and stomach. Ampulla is the site of fertilization. Leads to uterus, which is pear-shaped muscular organ. It consists of three layers: endometrium, inner lining that thickens during the menstrual cycle; myometrium, middle muscular layer; and perimetrium, outer serous layer. It leads to cervix, which is the narrow lower part of the uterus, opening into the vagina, produces cervical mucus varying in consistency during the menstrual cycle, and leads to the vagina, which is the elastic muscular canal connecting the cervix to the external body. It functions both as birth canal and facilitates sexual intercourse. Now a bit about ovarian function and follicular formation, which is called folliculogenesis. Folliculogenesis is the definition of the formation of follicles. First of all, the activation of pyramidal follicles happens on the resting phase, and the follicles begins to grow. Under the effect of hormone, follicular stimulating hormone, which is secreted by the ovary. Then the primary follicle formation occurs after the follicle cells become tubercle granulosa cells. Secondary follicle development happen with the formation of theca layer in the under the effect of increased estrogen production. Then there is the formation of fluid-filled cavity called antrum, and the follicles are called antifollicular stage. Then they enter into the pre-ovulatory stage, that is called grafting follicle, which means dominant follicle that will ovulate during the ovulation. Now comes the menstrual cycle regulation and the hormonal control. It has three phases: menstrual phase, follicular phase, and luteal phase. Menstrual phase starts from day 1 to 5. It is under the estrogen and progesterone level. Here the shedding of endometrial lining happens. Then the follicular phase, in which the FSH stimulates the follicular growth. Estrogen levels rise, leading to the endometrial proliferation and up till the ovulation day, that is on an average day 14. LSH happens here, which causes the dominant follicle to release an egg. This is called ovulation. And estrogen level peaks just before the ovulation. It leads to luteal phase, another effect of progesterone. When the this ovulation happens, the coprolitum formation happens in the ovary from the ruptured follicle. It stabilizes the endometrium by secreting the progesterone, which is also called the pregnancy maintenance hormone. These all things happen under the influence of gene RH, which is regulated by the hypothalamus. This is the pulsatile releases of gene and RH hormone, and which stimulate the pituitary to release the FSH and LH, which in turn release the progesterone and estrogen. Now, what is the role of hypothalamus pituitary ovarian axis? In short, we call it HPA. Hypothalamus, it releases the GnRH in pulsatile manner, and it regulates the secretion of FSH and LH from pituitary, which in turn cause the ovaries to release the estrogen and progesterone. Pituitary gland, mainly the anterior pituitary, which secretes the FSH, which stimulates the follicle growth during the follicular phase of menstrual cycle, and it also secretes the luteal hormone that's called LH, which triggers the ovulation and causes the corpus luteal formation. Ovaries, they produce estrogen, progesterone, inhibin, and activin. And These hormones they provide the feedback to the hypothalamus and pituitary to modulate the hormone level. It's called regulatory feedback loops. It inhibits the FSH secretion and activates it stimulates the follicle stimulating hormone release. Estrogen, progesterone in turn they modulate the GnRH and FSH and LH secretion, as you can in this associated picture here. Now, what are the etiology of female infertility? There are so many disorders that can affect the fertility. The first and foremost is ovulatory disorder. This disorder which involves the ovary, and the most common is PCO, that is called polycystic ovary syndrome. It affects 6 to 10% of women of reproductive age group. And diagnostic criteria is Rotterdam criteria, in which two of the following three should be fulfilled. There's oligo or anovulation. It means when the ovulation doesn't happen or it happens but with a delay, like 45-day cycle or more than 60-day cycle. We call it oligomenorrhea. Then there should be the clinical or biochemical signs of hyperandrogenism, including the hirsutism, increased facial hair, and the last is polycystic ovaries on ultrasound, in which you can see the periphery arranged follicles in the ovary on ultrasound, which is quite diagnostic of PCO. What is the pathophysiology? Well, here the insulin resistance happens, which leads to hyperinsulinemia and increased LH-FSH ratio, which promotes androgen production. How do we manage the PCO? You can go for lifestyle modification by diet and exercise, and then there are some medication like metformin, which counteracts the insulin resistance, and clomiphene citrate or letrozole, that's called letrozole for ovulation. That will be done in the forward slides. And then there is hypothalamic amenorrhea. The amenorrhea which affects the which is here because of the hypothalamic disorder. The causes could be so many, including the functional, when the stress, significant weight loss, and excessive exercises, it causes the amenorrhea. And organic, maybe the any tumors or inflammatory diseases which affect the hypothalamus, leading to amenorrhea. Mechanism, it decreases the GnRH possibility, leading to low FSH and LH, which leads to again infertility. Clinical features, it includes the amenorrhea, means no menses, or oligomenorrhea, again delayed menses. Here also happen the low estrogen symptoms like vaginal dryness, decreased bone density. The treatment consists of address the underlying cause. I mean, you treat the stress or weight loss, exercise thing, or you can either give the HRT, that is called hormone replacement therapy, if necessary, to maintain the milieu. Then there is called POI, premature ovarian insufficiency. We define the cessation of ovarian function before age 40. Etiology, genetic abnormality could be there, example Turner syndrome, or there could be autoimmune disorder affecting the ovaries, and there could be iatrogenic thing that affects the ovary, like surgery of the ovary, chemotherapy, or radiation, or maybe the radiation of the structure which are around the ovaries, in turn affecting the ovary and leading to ovarian insufficiency. The symptoms would be hot flashes, night sweats, and mood changes. How will you diagnose it? By diagnosing the elevated FSH level on at least two occasions. Why the FSH is high here? Because the feedback inhibition of follicular stimulating the estrogen progesterone is not there, as the ovary is not functioning, which in turn leads to the high FSH level. The management would be again the hormonal replacement therapy or fertility option including donor eggs. HRT is here to maintain the lifestyle basically, to ease the life of the patient. And fertility option will include the donor egg because there is no eggs in the ovary that you can induce by the drug. So you have to go for the donor eggs. Then there is called hyperprolactinemia. As the name suggests, there is increased in the prolactin hormone. The causes could be physiological, it means pregnancy or lactation, and pathological, where there are prolactin secreting tumors happens in the pituitary, which are called pituitary adenomas. They could be microadenomas or they could be macroadenoma. And there could be the effect of medication, which leads to increase in prolactin hormone, like antipsychotic medication, antidepressant medication, and their effect is it inhibits the GnRH secretion and reducing the FSH and LH and thereby causing infertility. The symptom would be galactorrhea, I mean, increase the secretion of milk from the breast, amenorrhea, or infertility. Diagnosis, how would you diagnose it? By diagnosing the elevated serum prolactin levels, an MRI of the pituitary gland will show you these adenomas. The treatment consists of dopamine agonists like bromocriptine and cabergoline, and the surgery or radiotherapy for macroadenomas if you found some. Now the tubal factor. The tubal factors are the factors which affect the tubes and then they lead to infertility. It could be the tubal blockage by salpingitis or hydrosalpingo. Now, what is salpingitis? It's an inflammation often due to the infection of the tubes, which leads to scarring and adhesion in the tubes. And hydrosalping, it is the accumulation of serous fluid in a blocked fallopian tube, which can be visible on ultrasound. And the consequences are impaired gamete transport and ectopic pregnancy risk increases. The diagnosis would be on HSG showing blocked tube. HSG is hysterosalpingogram. And treatment would be either you surgical remove or repair the tubes, or you can go for IVF, which bypasses these triple issues. Now there is pelvic inflammatory disease, which we call PID in short. It includes the infection ascending from the vaginal cervix to the upper genital tract. The common pathogens are Chlamydia trachomatis and Neisseria gonorrhea. The risk factor includes multiple sexual partners, unprotected intercourse, and prior history of STIs. Symptoms are pelvic pain, fever, and abnormal vaginal discharge. The complication would be fecal damage due to the infection, the infertility, and the chronic pelvic pain. Management would be prompt antibiotic therapy and partner notification and treatment. Then there is the endometriosis, which affects 10% of women of reproductive age. Basically, endometriosis is the founding of the endometrial tissue other than the uterine cavity. So whenever it happens, it leads to complication. The etiology is many theories are there, like retrograde menstruation and coelomic metaplasia theory. The common sites of endometriosis is ovaries, pelvic peritoneum, and rectovaginal septum. Symptom would be dysmenorrhea, dyspareunia, and chronic pelvic pain. The impact on fertility would be because of the adhesion that can distort the pelvic anatomy or inflammatory environment may affect the gamete quality. Diagnosis would be on laparoscopy with biopsy, and treatment is medical NSAID for the pain and hormonal therapies like GnRH agonists, and you can also go for progesterone therapy to subside the endometriosis. Surgical management would be excision of lesions by the laparoscopy. Then there are uterine factors which affect the uterus. It includes the fibroid, leiomyoma. Leiomyoma basically are the benign uterine tumors and they can found in up to the 70% of women by age 50. There are three types depending on the location. Submucosal beneath the endometrium, intramural within the uterine wall, and subserosal beneath the serosa. Basically, the intramural and submucosal are the ones which affect the fertility. Symptom would be menorrhagia, that means the increase in blood flow in the menses, pelvic pressure because of the increased blood flow in the uterus, and reproductive dysfunction because the submucosal they distort the uterine cavity and difficult implantation happens. The management would be myomectomy for fertility preservation and uterine artery embolization. However, we don't use uterine artery embolization much in the fertility factors because if the uterine artery is embolized, there is a decreased blood flow to the uterus and we need uterus for the fertile thing. Now we are uterine polyps. The overgrowth of endometrial glands and stoma happens and it could be pedunculated or facile and this also leads to infertility if it happens at the area of implantation. Symptom would be irregular menstrual bleeding or intermenstrual spotting. Diagnosis would be on ultrasound or hysteroscopy, and the so treatment is polypectomy or usually via hysteroscopy nowadays, or you can even go for DNC if the uterine polyps are small. Then there are congenital uterine anomalies. The classification is Mullerian duct anomalies that result from the abnormal development of the Mullerian duct. Type includes septate, bicornuate, didelphous, unicornuate uterus. It impacts the increase the risk of miscarriage because of the decreased this uterus area. It could lead to preterm labor and malpresentation if the pregnancy prolongs. Diagnosis would be on MRI, 3D ultrasound, and HSG. Management is surgical correction if it could be done. Example, hysteroscopic septum resection. Now there is one more thing that we call Asherman syndrome. Basically, it's the formation of intrauterine adhesions after trauma to the endometrium. It commonly follows dilatation in curettage and infection of the uterine cavity. Symptom would be hypomenorrhea or amenorrhea if the cavity of uterus is completely obliterated, which leads to infertility. Diagnosis would be on hysteroscopy, which is the gold standard, and you can also treat the thing then and there only by surgical lysis of adhesion. And postoperatively, we put the patient on estrogen therapy to promote the endometrial regeneration. Now come the cervical factors. Cervical mucus abnormality. The role of cervical mucus is it facilitates the sperm survival and transport during ovulation. Mucus becomes thin and stretchy, and it helps in ascending the sperm. However, when the cervical mucus becomes thick and hostile, mucus can hinder the sperm movement, and its causes include the infection or hormonal imbalances. How can you manage this? Either you treat the underlying infection, or you give the estrogen therapy to improve the mucus quality, or you can simply do the IUI. That's called intrauterine insemination This bypasses the survival factor. Now there are also the age-related infertility, in which important is ovarian reserve decline. The quantity and quality of oocyte it decreases with the age, and this accelerated decline happens after the age of 37. Then there could be chromosomal abnormalities with increasing age, which increase risk of aneuploidy leading to miscarriage or genetic disorders. Reproductive options include early fertility assessment and counseling, use of donor egg, or fertility preservation therapies like oocyte freezing for delaying childbearing. Most of the people are going for this technique nowadays. They freeze their oocyte in their young age so that they can use it in the later ones. Now, how will you go about this evaluation in the infantile patient? Patient history and physical examination is the utmost important. You go for comprehensive medical history, including the menstrual cycle details like regularity and duration of the cycle. Obstetric history includes the previous pregnancies and outcomes. Sexual history, it includes the frequency, timing related to ovulation, and contraceptive use history. Past surgery or any pelvic infection, family history of any genetic disorder or premature menopause, lifestyle assessment, which includes the smoking, alcohol, drug use, stress levels. Physical examination includes BMI calculation, the signs of hypoandrogenism is there like acne, hirsutism, and you can go for thorough examination along with the pelvic examination for anatomic and any kind of physical abnormality. And you can also check the ovulation as a part of this infertile workup, which includes the basal body temperature charting. Here, you ask the patient to take daily oral temperature measurement before rising. The slight increase of zero point 0.4 to zero point 0.6 degree Fahrenheit happens after ovulation due to the progesterone. So we ask the patient to see if there is a biphasic pattern, it indicates ovulation. If the monophasic pattern happens, it suggests anovulation. However, nowadays we don't use this much because there are many more different things are available for ovulation assessment, like LH detection. Nowadays, generally LH kits predict ovulation 24 to 36 hours in advance by measuring the LH surge, which causes ovulation. Progesterone level, if the serum progesterone level is greater than 2 nanogram per ml in mid-luteal phase, it confirms ovulation. And nowadays, most commonly we use the ultrasound monitoring, where we track the follicular to observe their development and then their rupture. You can also go for a hormonal evaluation of the patient before you start any treatment, like day 3 SSH and LH level, which indicates the diminished ovarian reserve if you find an elevated SSH level. Estradiol level, it is also assessed. Anti-Mullerian hormone assessment is done, which reflects the quantity of remaining follicles. File function test has to be done and prolactin levels has to be done. And now, the one of the most important thing is ultrasound examination. It could be TVS. Detailed image of pelvic organ to be taken, and it can also detect any kind of ovarian cyst, fibroid or polyp that can hamper your fertility. And it can also show you the interfollicle count, which means the number of small follicles in both the ovaries. They are a sort of indicator of ovarian reserve. Then you can also ask the patient to go for HSG and sonohysterography. In HSG, a radiopaque dye is injected into the uterus, X-ray taken to assess the uterine cavity shape and tubal patency. In sonohysterography, we infuse the saline during the ultrasound. However, it is basically used for intrauterine lesions. Then you can go for laparoscopy and hysteroscopy. Laparoscopy is a minimal invasive surgery using a laparoscope. Here you can see the direct visualization and treatment of pelvic pathology like endometriosis, and if there is adhesion, you can just treat them then and there. Hysteroscopically, you can examine the uterine cavity, and again you can treat the things if you find anything like polyp removal, septum dissection, adhesions are there in the uterine cavity. So laparoscopy and hysteroscopy are both diagnostic and therapeutic together. Then you can also go for genetic testing and karyotyping. The indications are recurrent pregnancy loss and POI under age 35. If there is any family history of genetic disorder. The tests include karyotype analysis for chromosome abnormalities and specific gene testing if indicated. There are also the lifestyle and environmental factors that needs to be taken into account, like impact of stress, diet, and exercise. Stress, it activates the hypothalamic pituitary adrenal axis and elevates the cortisol level, which can disturb the GnRH compatibility. Diet, malnutrition or obesity affects the hormonal balance. Certain nutrients they support the fertility, so better you ask the patient to take them.